All right. I just want to first want to say thank you to the Sandoval Symposium for allowing me to present my work here today. It is a true honor. So my name is Justin Fish. I am a student at Quinnipiac University, as John had said. I did my thesis research on post-cardiotomy via ECMO in single ventricle physiology. So congenital heart disease is one of the most common birth defects, which equates to roughly 1% or 40,000 live births. Prior to the introduction of cardiopulmonary bypass and modern therapy, the diagnosis of CHD would often be fatal and resort to palliative measures. These statistics represent all congenital heart disease. However, children born with single ventricle physiology represents an even smaller percentage. The formation of a single ventricle begins in the early stages of gestation at approximately 30 days. During the normal embryological course of events, various mechanisms could alter the formation of those two functional ventricles by a defect in either septation, poor alignment of the common AV valve with the ventricles. There's a wide spectrum of defects considered to be single ventricles, from hypoplastic left heart syndrome to tricuspid atresia. Initially, like most congenital heart defects, long-term survivability with single ventricle physiology was quite poor. With advancements in modern technology, as I had mentioned before, called cardiopulmonary bypass, survivability in recent years has reached 56.1%. These procedures introduce major hemodynamic changes within patients, and some form of mechanical support is not uncommon. According to DeBrunner in 2013, approximately 13 to 20% of patients require ECMO post-cardiotomy. This number increases to roughly 40% with single ventricle repairs, and survival rates decrease in these patients that require ECMO. There is not, however, much data comparing these patients in the early stages of repair compared to the late stages of repair. The aim or goal of this meta-analysis was to examine the survivability of these post-cardiotomy patients that require ECMO. I specifically looked at patients in the early stages of single ventricle repair compared to against the later stages of repair. Other secondary factors were examined as well. The results from this meta-analysis will provide clinicians with information regarding outcomes of these two patient populations, which will be able to aid in improving these outcomes. In this study, it was hypothesized that after repair of single ventricle physiology and implementation of via ECMO, there is no difference between the early and late stages of single ventricle repair in terms of survivability, hospital and ICU length of stay, neurodevelopmental and neurological outcomes. So materials and methods, I compared patients that were on ECMO after repair and not on ECMO after repair in both the early and the late group. Then took the results and compared them against each other to find out which stage of repair of a single ventricle are their favorable survivability results. The purpose of the secondary analysis was to evaluate hospital and ICU length of stay and neurological outcomes, more specifically stroke, intracranial hemorrhage, and seizures. Results of this data search were limited to clinical trials, case reports, randomized clinical trials, systematic reviews, and additional meta-analysis. Additionally, any publication that was produced before the year 1996 was rejected, and any qualifying articles found in the references section was also identified and used using the backward snowballing method. So inclusion criteria used in the early repair group included patients that were up to and including 2 years of age and less than 14 kilos. In the late repair group, patients that were older than 2 years of age but younger than 18 years of age were included, as well as patients that were more than 14 kilos. The patients required a diagnosis of a single ventricle. For the purpose of this study, only patients that were diagnosed with tricuspid atresia, hypoplastic left heart syndrome, double inlet left ventricle, double outlet right ventricle, pulmonary atresia with IVS, Epstein's anomaly, and AV canal were evaluated. The initiation of ECMO was also required within 24 hours from the time off bypass to eliminate other causative factors of needing VA ECMO. Any studies that included patients that required any form of mechanical circulatory support from the time of birth to the time of repair were excluded. Any study that also included patients on high-dose vasoactive support prior to repair were excluded. And finally, any study with patients requiring emergent implementation of ECMO due to cardiac arrest or any other non-life-sustaining rhythm were excluded. Okay, so 6 studies were used for the early repair group. Certain data points were extracted from each study, including the gender, the average weight, the age, the time to ECMO, sample size, and survivors. There was a total of 97 patients in the early repair group with sample sizes ranging from 6 to 31. 61% of the patients were male and 39% were female with a mean age of 101 days. So for the late repair group, there was also 6 studies that were used, however, with much larger sample sizes in each study with a total of 451 patients. Studies range from the year 2001 to the year 2020. 59% of these patients were male and 41% were female. So using a total of 7 studies, the sample size for the secondary analysis included 490 patients with sample sizes that range from 26 to 118 with a mean weight of 4.2 kilos, a median of 3.5, and a standard deviation of 1.371. The mean age was found to be 48.41 days with a median of 15 and a standard error of 19.21. There were a few articles that had incomplete information, so they were not used in the analysis of those variables. Studies 6 and 7 did not provide the number of males and females in their study. Zaki et al. Did not provide neurological complications, so is consequently not used in their neurological complication analysis. So the early repair group had a mean of 48.76% survivability and a standard deviation of 4.678, and a standard deviation, a mean of 43.67% and a standard deviation of 7.633. Using a confidence interval of 95% and a p-value of less than 0.05 to display statistically significant data, it was found after performing the two-tailed t-test that the data provide non-significant with a p-value of the data proved significant with, non-significant with a p-value of 0.096 in the early repair group and 0.301 in the late repair group. So the purpose of the secondary analysis was to determine if there were significant differences in the chosen confounding variables between the early and late repair periods. Neurological complications, hospital length of stay, and ICU length of stay were evaluated. The mean percentage of neurological complications in the early repair group was 30%, compared to 14% in the other group. The calculated p-value came out to be statistically significant at 0.043. The hospital length of stay and ICU length of stay is proved to be non-significant with a p-value of 0.163 and 0.201. So data shows that mortality and morbidity increases with the addition of ECMO implantation in both the early and late stages of single ventricle repair, as proved by Bacon in 2018 and Miller in 2018. The graph here, done by Jolly in 2014, reiterates that survival decreases in patients undergoing the Glenn procedure and procedure compared to all cardiac ECMO cases. The number of Glenn ECMO cases has also increased significantly over the past 13 years. So results from this meta-analysis showed, however, that the timing of repair does not affect the mortality of these patients undergoing repair, which was consistent with findings from Baker-Smith in 2015. Although the secondary analysis showed an increase in complications from ECMO and non-ECMO patients, most data points were non-significant aside from neurological complications. Patients that are placed on ECMO are 30 to 50% more prone to adverse reactions, according to Maneker in 2021. Results from this study confirm the work done by Maneker et al., showing an increase in neurological complications with the implementation of ECMO in this subset of patients when compared to patients that did not end up on ECMO. However, the results from this meta-analysis were contradicted by Bacon in 2018, which showed that neurological injuries were more likely to occur in the later stages of repair. This could likely be due to small sample sizes. It is also worthy to note that the hospital length of stay decreased when compared with the early repair group, which is consistent with the work done by Baker-Smith in 2015. So in conclusion, different stages of single ventricle repair did not affect the survivability of these patients that were placed on ECMO, which alluded to a failure to reject the null hypothesis that there were no difference between these two patient groups. The overall hospital length of stay decreased in the late repair group when compared with the early group, and the ICU length of stay increased but was not statistically significant. And finally, neurological complications were statistically significant in the early repair group. There were a few limitations of the study, which included the inconsistent and non-standardized care amongst the different ECMO centers. Due to time and availability, there were limitations set on the available data given the nature of the study and the data that was available in each study. The patient demographics varied amongst the studies and the data that was analyzed as they which appeared in those studies. There was a considerable lack of research comparing early and late repair in single ventricle physiology, and further research is needed to compare the two groups of patients. And these are the references. Thank you.